Okay, got it. And yeah, Shirley, what you'll see on the screen is just you and me. And then I've got the YouTube channel on.
Yeah, you're very delayed. It's very interesting.
Got it.
The sound is all right, but
Shirley, what you'll see on the screen is just you and me. And then I've got the YouTube channel on.
yeah, you're very delayed. It's very interesting.
Do you think you could?
The sound is all right, but
Shirley, what you'll see on the screen is just you and me. And then I've got the YouTube channel on. Okay, I just figured out how to mute that. That's good. I don't think you'll be hearing that echoing anymore. There's a little bit of a delay in how the YouTube is streaming, so.
yeah.
Okay, well, I am going to go ahead and introduce myself and you as well before we get started. Hey, everyone. My name is Michael. I'm with Nexus Motion. I'm a physical therapist in the Los Angeles area and also run a company called Learn Movement System, which we will talk about in a little bit. Right now, we have the guest of honor today. Dr. Shirley Sahrmann is here with us, one of my most important mentors and a dear friend. Thank you, Shirley, for being here.
My pleasure. I think it's developing that you're mentoring me more than I'm mentoring you, though.
Oh, yeah, right.
You know so much more about everything.
Absolutely not. Absolutely not. I was just trying to remind people with the newsletter. My motto is never miss an event with Shirley because you never know when the pearls are going to drop. Oh. So catch all of those pearls.
Well, I wish they were real ones.
Well, this is straight off of the Washington University PT Program's website. Just a little profile, your description of what you've done in your career for the very few people who don't know who Shirley is. She's a renowned teacher, researcher, and clinician. She began teaching in 1961 and spent 54 years educating 2 generations of physical therapists, was the first director of the movement science program. Shirley became the Catherine Worthingham Fellow of the American PT Association in 1986. Hence, you see the FAPTA initials after her name. And in 1998, she was selected to receive the Mary McMillan Award, which is the highest honor of the APTA. Of course, her first textbook, The Diagnosis and Treatment of Movement Impairment Syndromes, it's been translated into 7 languages, including Japanese. And her second book, Movement System Impairment Syndromes of the Cervical, Thoracic Spines, and Extremities, have equally been influential in teaching physical therapists and to embrace our responsibility to guide patients toward optimal health and functional independence through movement. Movement is the key word. Shirley retired, quote, I always like to put a big quote in retired in 2012, which is over 10 years ago, Shirley. But obviously that hasn't stopped her from continuing to teach students and many other physical therapists all over the world. So that's Shirley in a nutshell there.
Thank you.
So having been a physical therapist since, I guess, 1958, I'm sure you have seen, I'm sure you've seen a lot of changes in the way continuing education courses are being delivered. How do you think Con Ed courses have changed from what you saw back in the 60s to now?
Well, in many ways, there really weren't many continuing education courses when I graduated. Very few programs. And some of them were actually you had to go to the site where the teacher was and spend several days, a prolonged period of time learning their particular procedures. As you said, I started in 1958, so I actually had polio patients. The vaccine came out while I was in school. So the reason why I mentioned that now is because it wasn't until the sort of polio went away and the major treatment groups became neurological patients. And the big difference between the neurological patient and the polio patient is you knew what was wrong, causing their movement problems in polio because their muscles went away because of the loss of the spinal neurons. In the neurological patient, no one had an idea of what caused the movement dysfunction. So what that did was lead to the development of a lot of systems of intervention. Different people developed different treatment methods, the Bobaths, Brunstrom, Rude. And so all of a sudden there was a need to try to teach already graduates, already practitioners, what these systems were. So physical therapy at that point really became very focused on treatment methods, treatment regimes by some kind of expert. And basically the same thing happened with the manipulative or the manual therapy. So that sort of started the continuing, it laid a basis for the continuing education. And of course, we also weren't making much money, so you couldn't run around to all kinds of different places to take Con Ed courses. So most of what you were exposed to was through your chapter meetings or your district meetings, and a speaker would come in and sort of give you an orientation. So obviously, huge changes from then. People actually, because physical therapists became very valued, and I to be perfectly honest, in many ways, because we made money. We actually, when particularly after Medicare came in, we were really a source of revenue. So to be able to hire physical therapists because we didn't have enough of them, employers paid for continuing education. So when employers began paying for continuing education, then that spurred the increase in continuing education and the opportunity to go and take courses from people. And then eventually more people moved around. I would say in the 1980s, there was a little bit of attempt to try to record, provide continuing education that people would buy a package program and watch it on their own, as compared to going to a course or hiring a lecturer to come in. So that really spurred the growth of continuing education courses. And then topics also increased over time that were germane to physical therapists or that they wanted to know about. So opportunities, money being made, more people acquiring the expertise to do it. And of course, today it's an amazing number of courses. I mean, there are large corporations that offer pages and pages of continuing education courses. At first, the first big burst were when people were sort of coining the programs, like we had the McConnell technique from Jenny McConnell in Florida, and you still have like the Maitland courses. Pretty much they were aligned with a particular individual, but now it's a lot of topics. Almost anything you want to know, you can find a continuing education course. And then within the association, the different academies now are offering pre-recorded or all kinds of continuing ed. Certainly the pandemic and the opportunity for Zoom kind of courses and recording, people getting used to that has spurred additional large growth. So we've gone from nothing to an amazing amount of opportunity for continuing education courses.
Yeah, I think the virtual courses made a huge change or the trend these days. I feel like especially your outreach has just, I mean, you've been all over the world before the pandemic, but you know, since the travel restriction, you probably reached out to way more countries, the physios around the world, because you just had to like pop up in the Zoom screen.
Well, I don't know. The travel I did do get to a lot of countries, and I haven't zoomed probably to as many countries as I had visited for lectures. But it definitely saves a lot of time, and for many people it saves a lot of money, which is a really good thing.
Yeah. I'm just curious, when you were going through your earlier on, do you remember what sort of courses that were some of your favorite courses to take?
Oh, in some ways I didn't take a lot of courses. Uh, part of that is I was saying, when the continuing education courses came on, it was about and started growing was about the time I headed to graduate school. So I stepped out for 7 years while I got my PhD in neurobiology. And to be perfectly honest, I really never thought I would need to learn how to do any kind of treatment interventions again. I thought my life would be in the lab. In fact, for 19 years, I actually trained monkeys and recorded from their motor cortex, because the reason why I got my PhD in neurobiology was to solve the problems of the upper motor neuron syndrome, because I had spent 9 years as a clinician treating neurological patients, and it took me 9 years to realize that I didn't know what I was doing, and there was little hope I was ever going to know what I was doing. And so I escaped to graduate school to see if I could find out a little more about what was going on in this syndrome. So it didn't really spur me to try to take a lot of continuing education courses related to physical therapy. I was busy with going to research seminars and to conferences and playing with my monkeys, which yeah. So I'm probably not I'm not keen on how many courses I've taken, because to be quite honest, I haven't taken a whole lot.
Well, I think you took
You
yourself
know
to
what?
a whole new level of highest level of education, because you were in a PhD program instead of you know, like a continuing education courses. So you're
Right.
on
Well,
a different level.
and as I say, not only was I in a PhD program, I really didn't think I was going to be practicing physical therapy anymore. I mean, it's funny how life takes you in directions you never quite plan on, but it certainly did in my case. And you know, I was more interested at that point, because that's what the PhD program was, to try and understand mechanisms. And so at conferences, I of course went to the physical therapy conferences, et cetera. So the material that I would pick out would be ones in which people were trying to look at mechanisms and things, and every once in a while find out what sort of treatment techniques were being developed or emphasized.
Yep. Well, since last October, we have established this, I guess, a company called Learn Movement System.
Yep. Happily.
And what, in your eyes, what makes the Learn Movement System courses stand out from other continuing education courses?
Well, I think where we are and what we've been working on for so many years is understanding about how movement plays a big role in musculoskeletal disorders. And way back in 1973, Helen Hislop with her Mary McMillan coined the term pathokinesiology. And that term really means how movement is impaired by a pathology in contributing system, like what I was interested in, the neurological patient. If you had a stroke or a spinal cord injury or a head injury, your movement's impaired. But what I learned over the years, because I got sort of, I'll call it dragged or trapped, or not really dragged, but engaged in, again, looking at the musculoskeletal patient. And I had this background with polio, a lower motor neuron lesion, the upper motor neuron lesion. And that made me realize, or it really put it together with my colleagues who are so wonderful, that movement was a big cause of musculoskeletal problems. So I think where we're changing, what the emphasis we're trying to put in place is not treatment for isolated impairments, not treatment for symptoms as such, but how the treatment for movement, which is really behind causing musculoskeletal problems. I keep trying to deliver this message, which I think is like, to me, it was an aha moment, that with polio, with stroke and everything, everybody thought of these problems as acute. So you just hurt your back, you just hurt your shoulder, that it just did something. And if we got the pain down, strengthened them, the tissues would heal and we could go on our way. So we had to worry just about range of motion and strength. Well, working with a neurological patient, it became kind of obvious that that wasn't the way you did things with them. But it also, when I started with the musculoskeletal patients, it seemed like training them, looking at how movement impact this. And that's the big deal now. Like every other health condition, it starts early and then it progresses over time. So, and there are signs before there are symptoms. So what we've really tried to do is to show how movement and impairments, and that we call them syndromes on purpose, because it's not one little weakness muscle, it's not two little weakness muscles or a loss of range of motion. It's the whole activation pattern. It's the whole complex. So I think that's what we're so keen about. And we've also done our best to try to understand the mechanisms behind these adaptations that go on. So we're looking at how movement is a cause or an exacerbator of particularly musculoskeletal problems. How then, if we modify the movement, if we cite the impairment in the movement, look at the contributing factors that cause that and change it, then we're on our way to effective intervention. And I think that's the big difference, is we're not so focused on, we think the symptoms come from the way movement is occurring. And we're not, in fact, I never understood it when physicians would say, well, I'm going to give them pain pills so that we can send them to physical therapy. It's like, really? You're ruining everything for me, because I want them to come in with this pain so that I know how to teach them what causes the pain in the way they move and how to get out of it by changing the way they move. So I wasn't interested in some modality. I went through that years ago, where you were supposed to use a modality to get rid of the symptoms and then they could exercise. Well, we found out early on that if we changed the way they move, they could not only exercise, they could move. And of course, that's the big thing, is can I get back with my activities of daily living and do all the things I need to do? So I'd say that's what our major emphasis is, looking at movement as a cause. And I keep saying this, but I think it also changes the way physical therapists should function. And being that we hopefully will be someday on the preventive side of things, that people will see us so that we can identify the sign that's there, identify their structural variations. And also what I learned, it was a bit by bit over the way, that because when we examine somebody, we don't just examine the part that's problematic. we do an exam of the whole body, because you can't take one joint out of the body and only the orthopedic surgeon can do that. Right? One surgeon can do the knee, another surgeon can do the hip, even though it's the same bone. But the knee on one side is affected by the knee on the other side, affected by the hip, the trunk, the foot. And so we're looking at the total body and how it impacts the site that's become painful, because that's all the things that need to be addressed. And consequently, I never had this problem of, oh, now that knee's better, but now you developed a pain in this other place while we were trying to get that one knee to work better, which often would come up before in patients. So I'd say that's the big deal, is to try to look at how movements impair and identify the impairment, change it, identify the contributing factors. How has the musculotendinous unit changed? How has the joint itself changed? And then also, what are the activation patterns, the motor learning aspects of things?
Excellent. And, you know, the next big event that we're hosting is coming up on June 10th and June 11th. It's a 2-day weekend, 100% virtual course, which reminds me that, you know, everybody who is signed up for that course gets pretty much the best front row seats. Nobody's blocking view. And we'll do our best to make sure the live demonstrations go as clearly as we can with the handheld camera. But, you know, recently, just actually last month, you had delivered another weekend virtual course for the California PT Association. Thanks to Pearson. I always love supporting the CPTA courses where you come and teach all of us Californians. I got this question earlier this week from one of the participants who came to that CPTA course. How is the June virtual course going to be different from what you had just done in the April course?
Well, in part, you put your finger on one of it. It was just me. And the whole purpose of those courses, for the most part, is to let people know about how we're looking at movement and how effective it can be. So I try to provide the background. It's an orientation, but some participants are already thinking along that line and they get a little more out of it. I do demonstrations, and I always think this is really a useful aspect, so that you can see in many ways how people can even use telehealth eventually. Now, in the ideal world, you'd see somebody up personal first off, but it's possible to look at somebody. And the demonstrations are intended to to let people know what we're looking for, basically what the exam looks like, because an important part of what we also put together is a very systematic exam. As I was saying, you can't take one part out. So we have worked up, and again, I can't underplay or overplay the importance of my colleagues in helping to work all of these things out. So everybody's pitched in, they've used it, we've tested it. It's gone on and on how to use this systematic exam. So in the course for the California chapter, I show them basically what the exam's like, but these are a couple demonstrations. Anybody that can take away how to do it from that is totally amazing, because I think it takes a little more education than that and a little more exposure than that. So here come the values of what we're trying to do with the course that Learn Physical Therapy is sponsoring. And that's we're trying to teach people how to do these things. We have breakout sessions, and we have demonstrations so that participants will be able to see, to report on what they see. We'll be able to give them feedback on whether they're making the right decisions or not. So even though it's at a distance, there's going to be every attempt for them to learn how to do this exam, or if not in total, but to get enough of a baseline that they have an idea of what they're looking for. And, you know, and unfortunately, just from my time with all these continuing education programs, that fewer people are coming out with a good set of skills on how to observe movement, or specific muscle functions. And I think there's so many wonderful things to learn these days in physical therapy education, and there's so much of a push for productivity, that being able to really learn to apply the anatomy and kinesiology that you got in physical therapy school is a super challenge. And I think what we're doing is being able to show you how I always use a slide. I like a slide that says muscles don't take kinesiology. And that's because you learn all these things about, well, the quadriceps extend the knee, but so do the hamstrings. Now, yes, they're a knee flexor, but if your foot's on the ground and you extend your hip, you extend your knee. There's every way in which other muscles substitute, other actions substitute, and that's what you also have to know. So we're trying our best. And then the other thing that I think is valuable, as I said, for the California course, it was me, but you're going to be, people taking the course will see the interaction from my colleagues as well, the other faculty at WashU. And I think that's also a very valuable experience, because you hear different perspectives. Though we're all looking for the same thing, their way of explaining or looking at things can also be very beneficial as compared to just how I might choose to explain things. So sort of in a nutshell, we're working hard to show people how to do it, to make steps on the way of being able to do an exam. And this time we've decided to focus just on the low back so that we can do that as thoroughly as possible. We've come to grips with the idea over the years that unfortunately we throw out too much information. It's kind of like people are like deer in the headlights, like, where did all that come from? Yeah. And sorting it out. And I know myself, I would be the deer in the headlights if I was encountering all that information, which again is not typical information that people have. So that's why we're broken it up, so that this time we'll do the best we can in getting the idea about the back, the lumbar spine. And then in the next course, cover the hip, which, and I think I don't, well, I mean, I'm going to say it because I believe it, that I think there are few other therapists that have as much insight as to what's going on in the hip, not the hip joint replacement, but in the young adult hip that we've been working on for years. And I think that there's so much to be gained from these insights on how we're examining the hip. And it's not just a little simple basic routine. And then I think the other thing that we're doing that I hopefully will be essential for the profession is using diagnostic categories. That all of this examination, all this movement things results in labels, movement related labels. And it's always my hue and cry here that here's all these people becoming doctors, going to school for 7 years, spending lots of money to get their DPT degree, but nobody looks at them as doctors. And I believe that, I mean, I feel guilty about it because I was one of the people pushing so hard for the clinical doctorate degree. My reason was, when I got my PhD in monkey business, cat business and monkey business, the doctors had no trouble asking me for recommendations on their patients that they thought ought to have physical therapy. So I thought, well, golly, if everybody's got a doctor label, there'll be more equity in doctors looking at physical therapists than there is. Well, that has not turned out because we haven't taken on the other trappings of being a doctor. Because my overall belief, at least that's the way it is for me, if I go to a doctor, I want to get a diagnosis, or I want to know what diagnosis do I have to, potential diagnosis do I have to worry about. And I think until we clearly show that we are figuring out something, an orthopedic surgeon that Paula Ludwig works with wrote in an article that I think was so valuable that physical therapists look at patients in a different way. They're going to treat them in a different way. They need a label that reflects that different way. and trying to identify which tissue, and I don't know what I'd do anyway if I knew which tissue it was, except find out what movement made that tissue go bad. So that's a very long answer to a short question, but I think those are all the things we're trying to accomplish, is to show people how movement is a cause. There's the orientation thing, which is kind of the thing I did for the California chapter. This is what it's about. This is the way it looks. If you can learn this in 2 days, whew, that's mind-boggling to me, since it took like a lot of years. And maybe I'm just retarded, but I know I'm a slow learner. And we're trying to really now take it the next step and show people what exactly the exam's like, and how they can learn to do it.
Yeah, well, gosh, I would be the slowest learner in this room here. So, but I think the other big difference is in the CPTA webinar, you were able to do fantastic telehealth evaluation. So you weren't exactly with the painful subject in the same room. And
2,000 miles away, yeah.
In the June virtual course, there are actually going to be subjects with low back pain that are going to be in the room with you. So we actually get to see where you place your hands, what are you feeling, how are you doing each of those systematic examinations. I think that would be very helpful too. Yeah.
Oh, yes, that's what I say. You really get to see what it would be like in the clinic, in the physical therapy service, where you're really examining a patient, and then also teaching them what to do, what the treatment is all about. Yeah.
Yep. And we've got a ton of virtual lab assistants lined up for everybody. So we'll look forward to that. We actually have a live question from Nicholas Royer. Hey, Nicholas. So his question is, joint manipulations have become a standard scope of practice for new graduates more and more. What's your stand on that? Are we on the right directions with that?
Well, in some ways, I can a little bit, I'll put it this way. Our premise for the whole movement thing is that a joint moves too readily. And this premise is supported by Linda Van Dillen's research. And that's one of the things we're going to talk about in subsequent webinars. But it's sort of the movement part, and most of the manipulative things are to increase the movement of a part. Now, in some ways, the way they sort of fit together is that if one part of, let's just take the spine, if one part of your spine doesn't move well enough, you're going to move more in other parts. So the idea of making something move that is too stiff can theoretically make it cut down on how much movement is taking place in another part. The consideration is whether the movement that is occurring too readily then is still easier to move than the part that you've now been able to mobilize, because you're still going to take what we call the path of least resistance. The body's going to follow the law of physics, so it's still going to tend to move where it is. And I think once you see how this material goes, in fact, Linda Van Dillen again published a very big article in JAMA yet, showing that if patients figured out with the therapist guidance what movement was causing their pain, and then you have them not move there and learn to move in a different way, correct that movement, they got significantly more improvement that lasted over a year, and it only took 6 visits to do it. And this was compared to strengthening and stretching program. So I think that I'm sure there's indications for that, but in many regards, you still need to know how movement is eliciting symptoms, how you can change that movement and get rid of the symptoms. So
Great. Yeah.
that's my best answer for that.
Thanks, Shirley. Now, since you had mentioned about this upcoming webinars, the summer webinar series is a brand new addition this year. Give us an idea of just what those summer webinars are going to be like. You mentioned that evidence is going to be discussed in one of the webinars.
Yes, I think one of the fatal flaws of what we've been doing, we've been teaching continuing education courses for 30 years, I guess, is that we haven't really had continuity. We would teach what we called an introduction course, like a level 1, and then we do upper quarter, and then we do lower quarter. And again, I think it was just too much information, too sporadically given. And so what we're trying to do now is to provide a continuum of exposure and to build on that exposure so that you can get the bigger picture and acquire a set of skills. So because Linda Van Dillen has been doing so much research, particularly on the low back, I mean, that's what on the chronic low back pain, that there's evidence to look at what do we know and what don't we know. So she's really done an amazing amount of research, and it's so thorough and so good. And so that's why we also want to let people know that we're not just making up these things, but there's a good body of look and see and how does it work. And so that's why we want to do the evidence. But also because our attempt is to let other people know how to do exams and to learn how to do it. And in some ways, every case is different. Even though we have a diagnosis of lumbar extension syndrome, there's many manifestations of why somebody has a lumbar extension syndrome. It's not like everybody with an extension syndrome is going to have exactly the same program.
Exactly. Yeah.
So that's why we're adding on additional cases so that you can continue to reinforce this foundation of knowledge that we're then trying to put in place. So the webinars are going to provide the evidence, and then we're going to do some more cases so that you can continue to add to your, hopefully, repertoire on what do the exams look like and how to do them and the scope of patients that you can examine.
Yeah, and this is probably just a little bit of a repeat question, but the movement system impairment syndromes courses have been delivered to thousands of physical therapists in the last so many decades. Can you share how the MSI continuing education courses have evolved compared to maybe how they were taught 10, 20 years ago?
Well, I think in some ways, yes, the evolvement is, I personally was so keen about understanding mechanisms that as we first started teaching, well, I can tell you this, when we very first started teaching the courses, we had more anatomy because, you sort of found out that once people took their anatomy course and graduated, it was never to be considered again. I mean, like, who knew what the tensor fascial lata was? In fact, even now, what I've learned is that few people believe they have adequate information about how to assess the abdominal muscles and how to develop an exercise program. I always like to say the Australians have done such a good job of promoting the transversus that most people think that's the only abdominal muscle you need. And my standard line is, I knew the Australians would find it because they're both down under. But anyway, so when we first started teaching, we did a bit of anatomy. And then I was so keen to try and explain what was happening that we spent a lot of time on what makes for stiffness in the muscle. What happens when muscles, I got caught up in some basic things that in some ways people understand now, but they didn't think about then, is do muscles get longer? And then there was research in animals that said muscles do get longer. They can add sarcomeres in series. And it became clear to us that there were more problems because muscles were longer than because muscles were short. And then what does it mean by short? Because if it stretches out in 5 reps, is that short or tight or whatever? So we really tried to get very, very clear and very, very specific about what do we know about the underlying tissue adaptations or not. And then again, that didn't help people. I mean, I think it was all kind of interesting, but it detracted from getting the main messages about looking at movement. I can say early on, we had a systematic exam, but it wasn't as finely tuned as it is now. And so the way we've progressed, we sort of dropped the anatomy. Actually, now we're bringing it back a little bit because I find, as I mentioned, one, it's not clear about the abdominal muscles. The other thing is I've also learned that in the educational programs, people don't learn the shoulder girdle muscles as axioscapular, scapulohumeral, and axiohumeral. And that's the way they need to be organized to understand how they impact the shoulder. So we do a little bit of review just to let you know that muscles were moving joints before people were, and that it's important to know how they function. And so, now we've tried to emphasize even more the development of a systematic exam and the diagnostic categories, because we had basics about those categories, but now we've refined it. We've changed the shoulder around a lot as we've kind of worked with Paula Ludwig and our own clinical experience. As I say, we have research on the back and the hip. Nobody knew about the hip, and I was already talking about anterior glides, even acetabular impingement, when people thought you were just a little crazy. And of course, now it's all out there. So we have a lot of information about the hip that was that's those are the big changes. I think a little more practical, trying to get people to understand, a little less theoretical, which is fortunate and unfortunate, but it's a kind of a matter of what do we think has the most usefulness to the participants in a course.
Yes, as I said in the beginning, never miss an event with Shirley. And I think that goes the same for all of the WashU faculty as well, just because there's always these updates, and the stance is we need to continue learning as more evidence comes out. So there's always new things that I'm taking down in my notes, and maybe because I'm a slow learner, but that's okay. And so I'm always impressed with the evolution of how the materials delivered.
Yeah, I mean, just to pick up on that, this group is so committed to trying to understand mechanisms and what's going on and how to be effective. And that's why every year, probably for 35 years now, we would get together in what we call a retreat. And we would compare our notes, see what's legitimate, what we could find evidence for. And then I began to invite speakers that had expertise in muscle biology or biomechanics or whatever, so that we could again ask our questions and ask the experts, where are we on base, where are we off base, how does it fit with what we're trying to do and trying to teach. So we have this very strong commitment to trying to do the best at what everybody calls the best available evidence for things, but at the mechanistic level, not just at not just for treatment, but understanding how the body and tissues adapt.
Yeah. Shirley, we have a few more questions actually from the live audience. There are currently 24 people watching us on the YouTube. Thank you everyone for joining us. This question is from Howard Nelson.
Oh, hey, Howard, how are you?
So he asks, how much of an influence and or inspiration was Florence Kendall for you?
Oh, she was a big influence, I could say. One, because, particularly during the polio time, it was all about muscle testing. And believe it or not, I think that was the most quantitative era of physical therapy, because actually your senior physical therapist would assess whether you could, your muscle testing was accurate or not, because it was considered so important at that time. Now people barely learn it. And Florence was also a very rigorous teacher. She was she was almost like a parliamentarian, but she really thought quickly. I mean, thought a lot. And she was, when I started, then after I got my PhD in that, Florence was sort of out of favor because everything was neurological. And I said something good about muscle testing and the usefulness of it. And we had a common friend who lived in Baltimore, where Florence lived. And so we got together, and after I said something at a big conference favorable about muscle testing, I did a program with Florence after we got together, and she managed to assess my abdominals, etc. And
Well, I would love to see that.
Yes. And then we had an argument about muscle length, and because she said muscles were weak if your scapula was in an anterior tilt, and I said, how strong does it have to be? I'm not breaking a sweat by posteriorly tilting my scapula. So so we had great respect for one another, and her clarity of thinking was a real inspiration. And what she really inspired me to do was try to really use terminology that was accurate, and not just make up terms about how something's moving, but use the anatomical, kinesiological terms clearly. There were some things we agreed to disagree about, but she was really a big inspiration. In fact, so much so that I happened to be the speaker for CSM the year she died, and she died right before this speaker thing. So I was able to combine a eulogy to her with my speech for our CSM, and then her family asked me to represent the physical therapy program at her memorial service. In fact, her daughter had called me when she was dying, and asked if I would call her because she was talking to very few people. And anyway, there are a lot of funny stories about that, but she was definitely an inspiration in all of her thoroughness and desire to be on target and to explain what she was doing. Yeah, she was. Yeah, what was interesting, I watched her though. She had no hesitancy to let somebody know if they were off base. I mean, I'll never forget, somebody was doing a presentation at conference, and he was trying to talk about stretching the hamstrings, and Florence went right up on the stage and corrected him. I mean, she did not hold back at all, because she was such a purist. I mean, you either get it right or you don't say it. Yeah, I always worried when in fact, one time I gave a talk in Baltimore, and she was in the audience, and she said, Shirley, I'm going to have to leave early, so don't worry if I get up. Well, I'm talking, and all of a sudden Florence stands up, and she said, well, I just want to say one thing. And I thought, I've had it. I'm going to crawl out of here. And she was actually complimentary and rather than criticizing me. But who else in the world would stand up in the middle of an audience and just say, okay, I'm going to make a statement now? That was Florence. She was so critical, and I always wondered how she would be with her family. And then I went and stayed with her at her family's, and she couldn't have been kinder to them. She was so well respected and loved by all of her family.
Yeah, wonderful. I do remember your CSM speech, and it was a very touching tribute.
Yeah, it was easy to be inspired to say nice things about her.
Another question this is from Gillette Fitness. I'm entering into DPT school, and I've used your MSI system for about 10 years, which have helped me get and keep my clients out of pain. Do you have any recommendations for me as a DPT student?
Oh, to learn your anatomy and kinesiology as well as you can, and take every opportunity to observe the way your fellow students move and do things, and probably they'll all have musculoskeletal problems, and if you get to examine each other, try to put your observations behind it. I think, and also really trying to understand, how does this work? What are we treating? I think one of the faux pas is that we don't do enough about what is the condition I'm treating, and I don't mean that you've got a bad facet joint or a rotator cuff tear, but how is movement affecting those things? Just knowing about the anatomical structure isn't really enough. How does movement impact things? Because you'll be getting some of the basic science now. And how does my treatment affect this condition that I'm intervening in? How does it work? And I think those are really important things to try to get in your head as you go through school. It's not just learning what are the treatments, it's what is the condition, how does what my intervention affect the condition? Those are the big keys. Yeah.
Good.
Well, that's amazing. That you should be way ahead of the game by having such a background, because you already looked at a lot of people. This should be icing on the cake for you.
That's true. We're very excited for your journey, getting your degree, Gillette Fitness. I don't know what your real name is. And we have a bunch of questions from Vanessa G. I'm not sure if we'll be able to cover all of her questions, but I'll try to pick a few. Hey, Vanessa, thank you for joining us. Her first question is your experience, in your experience, does the movement impairment syndromes for the back pain apply to someone with scoliosis that usually have multiple curvatures?
Yes, but with a lot of modification, because some scoliosis are very flexible and some are very stiff, and usually the pain is associated with the part that's moving. So and you definitely have to take into account how everything's impacting that scoliosis. Again, I can't generalize on here's the very big thing. If you're really interested in scoliosis, there's this Schroth method, and I think they do more with exercise, and I think there's a lot of clues on their management that I would try to learn about if you're particularly interested in scoliosis as a treatment. In some ways it can be managed like the other things, but it's definitely, you have much more to think about as you're trying to change their movement, finding out what part is causing the pain, etc. Yeah, definitely much more complicated, but still falls into the same thing. In fact, in the older patients, you'll have degenerative scoliosis that'll also be in place, but that's a very different kind of picture than in the younger person who develops a scoliosis. The big thing, and again, my big advice is try to find out if this is somebody where their scoliosis changes readily, meaning they're very flexible, and the alignment can change, versus somebody that's really stiff and that scoliosis is really fixed. I think these days they just kind of jump to surgery pretty readily once they hit, I think, with 30 or 40 angle, something like that.
Yep. And I'll take one more question from Vanessa. What do you think about ballet dancers, their consistent overuse of their lower extremity turnout as an end range hip lateral rotation? They stand, balance, and jump in all of that turnout position. How would you help a dancer whose primary movement for ballet is in fact causing their pain?
Well, number one, as I mentioned very early on, I think prevention, I hopefully will fall into our realm of activity. And so number one is, before they become the ballet dancer, somebody should have assessed their hips to find out that don't have femoral anteversion, because that turnout is definitely going to be problematic. I think also many ballet dancers have hip dysplasia, which allows them to get turnout. So one's an assessment. Number two is, and I think this is the tricky part, is that it's okay to have the turnout when you're doing the ballet, but don't stay there all the time. It's just like the other part of ballet that creates problems is keep your shoulders depressed. So people hold their shoulders down, not just when they're doing ballet, but all the time. And the other thing that I find so interesting about ballet dancers too is in some ways, they don't get good abdominals. And part of it is because they're up on their legs and they use the quads and hamstrings to stabilize the pelvis. And that stabilization interferes with actual good participation of their abdominal muscles. So to me, there's a lot of little things to put together with the ballet dancers rather than just the turnout. The other thing you need to assess is whether the turnout is from the hip or whether they're also getting tibial rotation in the knee joint that's turning them out. So number one is don't let them stay there all the time. It's okay when they're doing their ballet. And particularly those people that are not going to go on to Broadway or are not going to be in some ballet dancing profession. And that's when you really need to bring them back to normal, because they're not going to injure themselves is not worth it when it's not going to be their career.
Very good. Thank you for that comprehensive answer. And yeah, to find out more about a lot of the details on the lumbar spine syndromes, those will be covered on June 10 and 11 virtual course. Sharon, you had asked a question about will there be another one? Unfortunately, no, but I'm working it out with the California PT Association that you will be able to receive CEUs for just purchasing the recorded course as well, even after the event is finished. And so you'll have recording access to most of the 2 days, just not the individual lab sessions that we'll be doing together, but the bulk you'll still be able to have access to it. And then what Shirley was talking about, more the details of the hip stuff will be covered in the fall. So thank you so much, Shirley, for it. I knew it was going to turn out to be a nice long lecture, and we're always so
I didn't have any slides.
Yeah, no slides, just off the top of your head. And yes, we're happy that many people came to watch this. It was my attempt to get more interest in trying to figure out what new ways to reach out to people who've never been exposed to the principles. So so thank you so much for your time, Shirley.
My pleasure.
I hope your eye gets better.
Oh yeah, it's doing better.
Yeah.
Yep.
Very good. Very good. Well, everybody, I'm going to close up the live streaming now. Thanks for joining us. And again, reminder that the early bird registration for the June course ends this weekend. So you can head over to learnmovementsystem.com and get signed up, and hope to see many of you there. Thank you, Shirley.
My pleasure. Take care, Michael. Good to see you.
Bye-bye. Okay, that's all for today's live streaming. Oh my gosh, this was the first time I tried to officially have a guest of honor and streaming it to YouTube. So thank you everybody for your patience, and my friends Howard and Nicholas and everybody watching. Thank you for posting your questions, and Vanessa. And I'm sorry we didn't get to all the questions, but hey, come and join us, and hopefully you'll get all your questions answered. And I'm going to close the streaming now. Thanks, everybody.